I'm very grateful for everybody here today and very excited to tell you about what pancreatic cancer metastasis is and then the role of biomedical research in tackling pancreatic cancer metastasis. So I'm Nikki Lytle. I am a assistant professor in the Department of Surgery here at MCW. I've been running my lab about 3 years now, and I'm just very excited to talk to you about some of the progress we've been making and then largely speaking, some of the progress the pancreas cancer group has been making here at MCW. Um, so I'm just gonna start by talking about what differences between cancers. So a lot of the people on this call probably know that you know cancer rates are different depending on the site or the location of the cancer. For example, by the way, Olive, can you see my pointer here?
Yes.
Great. So for example, about breast cancer accounts for about 30% of all cancers in women. And if you look over in men, about 27% of those cancers in men is all prostate cancer. And then you can see, lung is quite common, so is colorectal cancer, so on and so forth. Pancreas is not shown here because it's relatively more rare than a lot of the other cancers. But everyone on this call knows that is not necessarily a great thing. I mean, it's good that it's low incidence, but unfortunately, because treatments are such a challenge right now, the incidence of death from pancreas cancer is actually higher than most of these that we're showing right now. So, the type of cancer actually really guides what treatment is given to those cancers. We can't treat all cancers the same. So, what are the cancer treatments? Some of these, obviously, everyone here is very familiar with. For example, surgery was probably one of the first treatments we had for cancer. And that is because if we can just surgically remove your tumor from you and you no longer have cancer in your body, then you are cured. And that is a wonderful thing. But as you know, there's actually a lot of challenges with that. Many patients are not surgically resectable because of the disease state. Either it's already spread to too many organs, or maybe your cancer has wrapped around major nerves or arteries that make it impossible for surgeons to remove that cancer. So, again, surgery came about, many years ago. And you probably heard a lot about surgery from Dr. Doug Evans, who I believe already gave his lecture in this series. But after surgery, then there was this advent of what we call cytotoxic therapies, and that includes chemotherapy or radiation. And what do we mean by cytotoxic therapies? It means that it's not targeted to specifically your tumor. What it's targeted to are cells that are rapidly dividing. So there's cells in your body that are like copying themselves over and over again. And in that regard, it can be really effective against cancer because cancer cells are rapidly dividing and growing out of control. That's really what makes them cancer. So those are great. But there's unfortunately a couple things that this falls short on. One is that not all of the tumor cells in your tumor are rapidly dividing. So those that are more what we call quiescent or they're not dividing, they tend to be resistant to these therapies. The other thing is anybody who's received chemotherapy or radiation or has had a loved one that have received those probably knows that they actually have quite a few side effects as well. Those side effects often impact your skin, your gut, your liver, your kidneys, these organs that can be quite sensitive to cytotoxic chemotherapies, and therefore they're limited in their capacity to treat cancer patients. So where did we go from there? Now we're starting to get um, a lot more into the more recent impact of biomedical research in cancer treatments. Now, granted, chemotherapy and radiation, those were also had come about because of researchers, but those on the order of 100 years old or more recent chemotherapies. But now we're moving into some more what we call like targeted treatments. So, for example, hormone therapy. I'm here talking to you today about, um, pardon me, about pancreas cancer treatment, but which, hormone therapy does not apply to. But just as an example, there's breast cancer subtypes and prostate cancer that are really dependent on the hormones in your body. One example of that is estrogen receptor positive breast cancer, which occurs that or which essentially represents about 70% of all cancers in women, breast cancers in women. And those estrogen receptor positive tumors really depend on estrogen. So biomedical researchers found out a couple decades ago that if you deprive the tumor of that estrogen, the tumor essentially just melts away. And that significantly improved survival for those breast cancer patients. It also really helps. Androgen receptor therapy is also very helpful for prostate cancer. But unfortunately, that's not really helpful for pancreas cancer since to our knowledge right now, there's not a ton of dependency on hormones. But then there's immunotherapy. Now, I said that immunotherapy is kind of more recent, but maybe that's not exactly the truth. This is one of my favorite little historic snippets of what researchers have done to get to what's called immunotherapy. So I'm going to go all the way back to 1891, and this is an oncologist named William Coley. And he was, I'm going to say, quote unquote, treating cancer patients. I'm putting that in quotes because in 1891, we did not have chemotherapy. We did not have radiation. And in fact, we didn't even have anesthesia, which meant that surgery was a big problem. So he was treating patients. I don't really know what that means, but what he was doing was he had patients with cancer come into the hospital that he was treating them at, and because there were no antibiotics at the time either, some of those patients actually got very sick with bacterial infections. And what he noted, this is again back in the late 1890s, what he noted was that if those patients got very sick with an infection, a bacterial infection, and then their body essentially cleared that infection, sometimes those patients also cleared their cancer. So their cancer went away following that infection, which was very shocking for a lot of people. So William Coley, bless his heart, did not quite know everything that we know today about science and disease. And so as a result of that, he started injecting his patients with bacteria to give them this infection. And as you might guess, many of them died of that infection. But again, the ones that survived sometimes cleared their cancer. Not surprising to anybody, that didn't last very long because way too many people died. Okay, well, how is that story related to immunotherapy? So immunotherapy is actually the idea that we are harnessing your immune system to target your own cancer. And he didn't know it at the time, but he was actually the great grandfather of immunotherapy. And I say that because what we now know is that in those patients that had those overt bacterial infections, their immune system would get really ramped up to fight it. And then part of that ramping up is suddenly the immune system in their patients would see their own cancer and then attack it and clear it. So was that successful? No, but what we now know is that he was actually on something that 100 and maybe 10 years later was refined into what we now know of as immunotherapy. And this was major discoveries made by Jim Allison on the left and Li-Ping Chen on the right. And they discovered what's called CTLA-4 and PD-L1. And what those are molecules that your tumor cells express. You can think of them as like cloaks where they're hiding from the immune system. But if you uncloak the tumor cells by blocking those two molecules, suddenly your immune system can see the cancer and attack it. So now, this is an example of biomedical research that started in 1891 and then went all the way to today and has resulted in a therapy that's been amazingly effective, particularly for melanoma, some lung cancers. There is still great interest in applying this to pancreas cancer as well. Although so far the clinical trials have not been very promising, there's still a lot of work to understand what we can do for pancreas cancer to make it more responsive to these immunotherapies. So the one thing that I want you to take home from all of this is that cancer it's used as one term, but truly it's a collection of many diseases, and we want to think of it not as one disease, and it's really a collection of a bunch of diseases where the treatment depends on what the cancer type is. So I gave you examples of breast cancer, melanoma, lung cancer, prostate cancer, all of those cancers over the last 30, 40 plus years. Biomedical research has led to discoveries that have made substantial contributions to survivorship. So what does that look like? What I'm showing you here is a graph that shows the percent of patients that live to 10 years after diagnosis. The green bar is the 10-year survival rate in 1971, and the pink bar is the 10-year survival rate in 2011, so essentially 40 years later. And what I want you to focus on is the fact that, for example, in 1971, the 10-year survival rate of prostate cancer was 25 years. That more than tripled to 84% by 2011. Bowel cancer more than doubled. Leukemia, shoot, I don't even know, it's like fivefold increased in its survival. Skin has almost doubled. You know, all of these cancers, substantial improvements. Now, however, what I'm about to show you is a little bit disheartening, but hold on, I will tell you where we're going. But at the very bottom there is actually pancreatic cancer, that the 10-year survival rate in 1971 was 1%, and the 10-year survival rate in 2011 was 1%. We did not make a whole lot of progress in that time frame, but what I'm not showing you is the last 15 years where we have made substantial strides to improve that cancer outcome for pancreas cancer. The 5-year survival rate for many, many years was stuck at 6%. It is now 13%. And we think, given some of the new discoveries that I'm going to talk about, we will continue to push that well beyond that 13%. So the one treatment that I didn't talk about so far is what's called targeted therapy. So targeted therapy, you can think of it as like personalized medicine. So your tumor not only has a unique set of it's number one, the location matters a lot. Again, breast, pancreas, so on and so forth. But beyond the location, the mutations that are driving your cancer are also very important. So we now have been working, we meaning the biomedical research community, has been working for the last couple decades to bring precision medicine to everyone, meaning that based off of your tumor, your location, your genetic drivers, what are the mutations driving it, that we will give you treatment based off of that. We haven't gotten there for all patients. We've slowly been working towards that based off of the various mutations that we begin to understand more about, but there's still quite a few that we have no targeted treatments for. But in addition to the targeted treatment, I'm going to talk to you in a little bit about my own research, where we are trying to generate new means of discovering new targeted therapies based off of the communication with your body. So the one targeted therapy that you I bet a lot of you have already heard of is now an inhibitor against a protein called KRAS that, when mutated, becomes activated and stuck in this active state here. And that active KRAS triggers a bunch of signaling within a cell that really drives cancer. And this one mutation is found in between 90 and 95% of all pancreatic cancer patients. Now, for decades, we knew KRAS was so important, especially for pancreatic cancer, but it was considered undruggable. And it was considered undruggable because despite lots of efforts from wonderfully smart and creative chemists, we just could not find anything to drug this with. But then luckily, Kayvon Shokat in the last 10 years-ish was able to find a way to actually drug that active KRAS. And now KRAS inhibitors have been in clinical trial for pancreatic cancer. And as you can see, after that first discovery, once we learned from that discovery, there was a slew of new inhibitors that came out. You can see all these lists of inhibitors. And there's a lot of work right now clinically trying to figure out which inhibitor is best and for which patient. So What does that look like for pancreatic cancer? Again, like I said, it is in clinical trial, but right now there's one drug that hits all of KRAS, both the active and inactive form. And that clinical trial, oh, I'm sorry, I think that turned out blurry, but that clinical trial has been very promising. So what this looks like is called a waterfall plot, where at the time that patients are enrolled in treatment, that their tumor is measured, and that's considered time zero or baseline zero. And then as the patient is treated, their tumors are imaged, and you can track whether the tumor shrinks or grows. If it shrinks, then the bar goes downward here, meaning that there's negative growth. And you can see that in all of these patients treated, these are all individual patients treated with this KRAS inhibitor, the vast majority of them shrunk to some degree, and some of these patients almost had a full response there. So we think that this is a very promising next approach for pancreatic cancer. And most likely, all pancreatic cancer patients will be getting KRAS inhibitor at some point in their treatment, probably with chemotherapy. I think I saw a question pop in here.
Yeah, I
All
can
of
read it to you, Nikki, if you want.
yeah, that would be fine. Thank you.
Um, can you get an accurate KRAS result from only a blood test and not a tumor biopsy?
That's a great question. And for the most part, yes. The blood tests have been becoming very, very sensitive. So even a very small amount of mutant KRAS, either as the form of like, we call it extracellular DNA, so it's DNA that's floating in your blood, we are typically able to pick up very low amounts of that in your blood. Now, that being said, if your total tumor volume is too small, it's like really microscopic, it's possible that we won't be able to pick it up. So that just as long as you have enough tumor in your body, we absolutely can pick up this mutant KRAS. Now I'm guessing you're wondering about early detection, right? It's whoever asked that question. I think we have a couple more in the chat, but real quickly on the point of early detection is there's a lot of effort to identify people who are at higher risk of pancreatic cancer and to start to do screenings such as this. And in fact, MCW here, we do have a clinical trial for patients at high risk of pancreatic cancer, and we'll do screening for those patients to hopefully catch it at the earliest stage of tumor initiation. Was there a second question there?
Yep. There's two now.
Okay.
One says, why are MDs not testing us for KRAS? I am stage 3.
Oh, I'm so sorry to hear that. That is really, really tough. And also thank you for being here and thank you for sharing your story. That's always brave. So one thing is how do we test everybody? There's about a total of 55,000 new pancreatic cancer patients diagnosed every year in the United States, and there's over 350 million people. So that is the tiniest fraction of the population that gets diagnosed. Now, obviously, your story, it just hits everybody's heart. Like that's your life. Yes, you are a tiny fraction of the United States, but should you have somehow been caught earlier? One issue we have is who do we test for this? And then beyond that, how do we convince the insurance companies to cover more people to be tested for this? Notably, there is what's called a pan cancer blood test that is currently in clinical trials. And that blood test will be able to detect any cancer. That's a little scary for some people because let's say you test positive on that cancer test, and it comes back and your doctor says you have cancer somewhere, and then you do a scan and you don't know where the cancer is. Where do you go from there? So absolutely, there's a lot of effort moving in that direction. The more we can catch people early, the better across the board. So I wish I had a better answer for you other than unfortunately, it's just right now insurance companies and so on and so forth don't want to test 350 million people yearly for this. But if we could figure out and convince that like if you have this that you should be tested, then we will catch more people. Any other questions? And feel free
That's
to
it.
unmute yourself as well. I love this is actually a perfect spot because I'm going to go into my lab next. So this is a great spot to pause and talk about this.
Another question in the chat is when you say tumor volume, does that refer to the tumor size or antigen number?
Here it's tumor size, so it's measured by either CT or MRI. We do also track indicators of your disease by blood. Some people may have heard of what's called CA19-9. CA19-9 is correlated to pancreatic cancer in, I believe it's about 80% of patients. There are some patients that don't have any CA19-9, so that's troublesome. But you can also track, let's say, this mutant DNA in your blood through time as well, and track to see if that goes up and down. And that would indicate that your tumor is shrinking or growing.
The next one is my pancreatic tumor from the pancreas head was too small to test because it was shrunk by chemo treatment prior to the Whipple surgery. How can I test now for KRAS mutation after 5 years?
That's a great question. And by the way, I'm always so happy to hear when people have a wonderful response to chemo. That is very predictive of good outcomes. But now at this point, there are panels of how do I put it? It's like what they're looking for in your blood. You can have a panel of about 55 known mutations, for example, that are linked to pancreas cancer. So they don't have to know your specific mutation. They will just look for the most common mutations that are present in pancreatic cancer patients. So you could still have a test like this done. And this is something if you got treated here and continue to get treated here, for example, Dr. Kamgar, who I believe already gave a talk as well, absolutely she works, and Dr. Dave So and Dr. Evans, they all work a lot with kind of these companies that do these blood screening platforms.
Thank you. And yeah, just to chime in there, I was at Dr. Kamgar's talk
Okay,
and I think the treatment team would be able to talk about the specific testing with you. So just talking to your overall treatment team might be able to get the blood test.
absolutely. Thank you, Olive. Yeah, these are all things that we try to be at the forefront of the best opportunities for our patients, both in terms of detection, treatment, surgical intervention, radiation intervention, all of it. So, absolutely, just continue that conversation. All right, if there's no other questions, I can move on. Yeah.
Yep, you're good.
Okay. So now I just am going to transition. I'll just give you a small bit into what my lab does here at MCW. Um, Now it's going to be, I apologize in advance. There's going to be some science to it, but I promise I would love to answer any questions that you have, and I think you will still enjoy what I want to talk to you about. I have to first start in giving my lab credit, although I got to say this picture is a little bit outdated, but I can't let it go because that's my dog there, Dolly Parton, in a tutu, and it's just my absolute favorite photo ever. But we've grown a little bit more, and I have this amazing group of PhD students, so they're working on their doctorate degree. I've medical students there, they're working on their medical degree, but they're interested in research and doing research. I also have a postdoctoral fellow. She already has her PhD, but she's doing additional training before she hopefully goes and starts her own lab. And this mix of people have just been absolutely the drivers behind all the work that's coming out of my lab, and just have been such a pleasure to work with on a daily basis. So we think a lot about metastatic recurrence. So what is metastatic recurrence? Okay, so about 20 to 25% of all pancreas cancer patients are diagnosed with what's called early stage disease. So what that means is that it's contained within the pancreas itself. It has not spread yet. And those patients often come here to get treated, particularly because of the skills of Dr. Evans and his team at being some of the best in the world at removing pancreas cancers. So patients come in and then they're treated for about 6 months total, often, with combination chemotherapy and radiation therapy. And this can change depending on whether or not that person has kind of struggling with increased toxicity, or maybe their tumor's not responding to chemotherapy. Here, it's not one single regimen. The regimens that we give people can change pretty rapidly depending on whether or not their tumor's responding or not. So after that treatment, they go on into surgery. What I'm showing here is a Whipple, but there's different forms of surgery that can go on. And then at that point, the patients are monitored through time. Okay, why are we monitoring them? It's because we're looking for signs of what's called recurrence. So at the time of surgery, there is no indication that these patients have any disease in their body. Most of them, that CA19-9 or other markers of disease have really come back down. There's no disease in the pancreas, the margins are clean, so on and so forth. But what happens is, over time, some of these patients come back and they have disease in their distant organs. So how does that happen? It happens through a process called metastasis. And this is when tumor cells leave your primary tumor in the pancreas. They enter circulation, they travel through circulation, and then they exit and they land, and we call it disseminate. So they disseminate and land in distant organs. Now, that's one thing that's kind of scary about this, is that we know that it occurs actually very, very early in disease. And in fact, most patients, even with the tiniest little stage 1 tumor, we can see those patients still have circulating tumor cells. That sounds scary, but the truth is that this process is incredibly inefficient. And in fact, tumor cells that leave the primary tumor travel to distant organs and then seed those distant organs. The vast majority of them will die because your immune system clears it. It's hard for your immune system to essentially clear a whole tumor. It's much, much easier when it's a single tumor cell somewhere in your organ. However, for an unfortunate set of patients, that rare little indication that a tumor cell landed in a distant organ, it was able to survive, and then eventually start to grow out again and give rise to new tumors. So it is rare, but it happens in too many patients. And so what do I mean by that? This data is a little bit old at this point. It's about 10 years old, actually. We're doing a little bit better than this, but this is generally speaking the trends. Okay, so the blue bar here, oh, sorry, let me back up here. What we're looking at is months from diagnosis here on this bottom axis. So that's time. And then what this is the proportion of patients who are surviving. So as this goes down, it's indicating that patients have died of their disease. So this blue bar are patients that were originally deemed surgically resectable, but for various reasons, they never went through the surgery. And you can see that their survival is very, very short because their tumor was not surgically removed. That gray section there that I'm showing, that's kind of that time frame where their patients are getting treated and they're really heavily monitored. All right, so then after surgery, which is the end of this gray bar, there's about 1/3 of patients here. So again, these were disease-free patients. About 1/3 of them will recur with disease in distant organs within months after surgery. So it's very aggressive in about 1/3 of patients. 1/3 here will recur with disease about 1 to 5 years after surgery. And then about 1/3 will either never recur or recur very long after their surgery. And right now, we almost have no indication as to when you go to surgery, which of these thirds are you in? Are you in the third that's at very high risk, or are you in the third that will likely live very long after your surgery? So this is why I think so much about recurrence. Imagine, going through all that treatment. Maybe some of you have, and then some of you may have gone into surgery, and none of that is easy. So going through all of that just to be told that your disease came back within a couple months is something that I just think about constantly. How do we do better, and how do we get more people into this blue bar here? Okay, so I told you that patients go through about 6 months of chemotherapy before surgery. Um, right now, the majority of patients are treated with kind of one of two regimens, although again, things can change throughout their treatment because maybe you have toxicity, liver toxicity, kidney toxicity, or maybe your tumor is not responding, so then we'll switch you. And so what that looks like is either something called FOLFIRINOX, and this is a combination of 3 chemotherapies plus folinic acid, which helps enhance chemotherapy efficacy. So there's FOLFIRINOX, and then there's gemcitabine with nab-paclitaxel, also known as Gemabrax, and that's a combination of 2 chemotherapies. So we kind of use these very cytotoxic, aggressive chemotherapies in an effort to shrink that tumor as much as possible to ensure that we get as much of your disease out as possible. However, I told you that about 1/3 of those patients recur within months post-surgery. And I also told you that their tumor cell dissemination can happen very, very early even prior to diagnosis. But what I didn't tell you is that there's actually a lot of evidence that tumor cells continue to disseminate even through treatment. So even at the time of surgery, if we measure blood in your peripheral blood, or even the blood in the major vein that goes between your pancreas and your liver, we can find those circulating tumor cells. So we know that that dissemination is essentially a problem throughout the entire time you're being treated. So we got to asking, okay, we know that chemotherapy is linked to liver damage. And we know that tumor cells are really spreading throughout that treatment period. And also, by the way, I didn't mention, but the vast majority of the early recurrence is all in the liver. So is it possible that chemotherapy-induced liver damage creates a tumor-supportive liver niche that leaves patients at high risk of recurrence to the liver? So we're able to test this in mice. So I am a basic scientist, even though I'm in the Department of Surgery. But what I'm allowed to do is really do a lot of testing in mice. And this enables me to both genetically manipulate them, try new drugs, try new things that I can't do in people and I would never do in people. Did I see, by the way, were there additional questions, Olive?
Yep. There's a chat. It says, if recurrence is an issue after surgery, should research be targeted to treat after surgery patients with drugs to eradicate those hidden cancer cells?
Whoever asked that question, you are a wise, come to our team. This is what we think about all the time, and I will get to our efforts to tackle that here. And in fact, I want to I'll highlight it at the end again, but Dr. Kamgar and the team has actually a very unique clinical trial right now that's not really, we might be the only site really doing it, where we are trying to identify patients that are at high risk of recurrence and then treating them with precision-based therapy, so for their tumor, even before there's signs of recurrence, because we know that you statistically will recur. Now the problem is that we're not quite good at figuring out who's in that dark red category versus blue category, and it doesn't make sense to just treat everyone because there are a good fraction of people that'll never recur. So number one, we have it ongoing. We have a clinical trial for this. And then I will talk a little bit in the end about how do we refine to identify who should be getting those treatments. So, how do we test this in mice? This idea of chemotherapy damage to the liver maybe impacting your risk of recurrence. I treated mice with either chemotherapies that are very relevant to pancreatic cancer or control. And this was to model the damage that happens to the body versus no damage to the body. And then I took these pancreatic cancer, they're little organoids that grow in 3 dimension, and you can think of them as little mini tumors. And then I treated those mini tumors with the same chemotherapy that this mouse received. So now all of the cancer cells have seen chemotherapy. But then what I'm testing is, okay, what is the impact of the body being damaged by chemotherapy or the body not being damaged by chemotherapy? And then what we can do is we can introduce those tumor cells into the liver via what's called a portal vein injection. And this is a surgery that we go into these mice and we put those cells into their portal vein that is essentially a highway from the pancreas to the liver. And then we can track these mice for survival, try to understand what happened. And what we found, it was very, very striking, is that if we treated a mouse, again, this is prior to transplantation, then we stopped treatment and introduced the tumor cells and just tracked them for survival. If the mouse is treated with a drug called oxaliplatin, part of FOLFIRINOX, those mice died so much faster of their liver metastasis versus no treatment. And again, this is only the damage caused by the chemotherapy to the body. And here, because we're studying liver metastasis, it's the liver damage. So this was a bit concerning. However, patients don't just receive oxaliplatin, they receive. So we repeated this study using FOLFIRINOX shown in blue here. And then we compared that to FOLFIRINOX, but that was no longer containing oxaliplatin. So that's called FOLFIRI in purple compared to vehicle. And what you can see here is, again, the mice that were pre-treated with FOLFIRINOX died so much faster of liver metastasis than mice that were pre-treated with FOLFIRI or nothing. So this tells us that, number one, liver damage from chemotherapy can incidentally accelerate metastasis in the liver. And number two, we really think that this oxaliplatin is kind of the bad culprit here. I do want to pause and just say that chemotherapy during that time, after diagnosis and before surgery, has definitely helped patient survival. It gets more patients into surgery. It gets more clean margins so that you have no more disease in your pancreas. And overall, if you receive neoadjuvant therapy, you do better than patients with none. What we're showing here, though, is, okay, great. The chemotherapy is effectively killing some of the cancer. But what we think is what remains might be a little bit more at risk because of that liver damage. So what can we do to protect your liver during chemotherapy? So we got to looking at how livers heal after damage. And this has been very well worked out because a lot of people may know here, your liver is incredibly regenerative. If we remove 90% of your liver, that little 10% that remains will actually grow back into a full liver. It's actually completely crazy. And so a lot of work has been done to understand in the biomedical research side, how does that happen? And so what I'm showing you here is a summary of all these little growth factors here that you can see that essentially the cells are secreting and communicating to each other to say, like, hey, we have damage, we need to heal. And what was striking to me when I looked at this was actually a lot of these factors that are present here and involved in liver regeneration are the same factors that we actually feed our tumor cells in a dish so that they'll continue to grow. So what if the liver regenerating is accidentally feeding those tumor cells that are residing in the liver? So we took two approaches to really understand factors that were upregulated in that oxaliplatin damaged liver versus control. And I know this doesn't make a ton of sense to you, but I'll show you a little bit of the data. One is that we looked in what's called liver interstitial fluid. So that's the fluid that's kind of in between cell spaces in your liver. And really what we're capturing in that fluid in between your cells is all those factors that are being secreted and communicating to each other. And we could do proteomic analysis on that. And then the second thing we did was called single cell sequencing. And what that does is we can take a liver out and do a sequencing analysis and ask what cells are present and have they changed because of the chemotherapy. So now we're looking at what's secreted and then what cells are present. So first on that proteomic side, so that's that secreted factors in the liver. The first thing that really popped out as profoundly elevated in the oxali damaged liver was a protein called TIMP1, TIMP1. We saw that it was elevated in the oxaliplatin damaged liver. It was not elevated with gemcitabine or 5-FU or irinotecan, which are other chemotherapies that are commonly given. But it was also elevated in another so this is oxaliplatin and this is cisplatin. They're actually very related chemotherapies. So we think that it's actually a platinum-based therapy that is inducing TIMP1 here. Again, patients don't just receive oxaliplatin, they receive FOLFIRINOX. So again, we looked at FOLFIRINOX, and we could show again, TIMP1 is elevated following FOLFIRINOX, but not FOLFIRI. So it's that oxaliplatin-based component that seems to be driving this. Okay, that tells us that, all right, oxaliplatin drives up TIMP1, but is that actually doing anything to promote metastasis in the liver? So we repeated those survival curves that I just showed you where we pre-treat mice, stop treatment, transplant cells, and follow them for survival. What we're showing here is oxaliplatin in blue versus vehicle. And again, the oxaliplatin treated mice died faster of their disease in the liver. But if we paired that oxaliplatin with a drug that depletes that TIMP1 protein, so TIMP1 is gone now in the liver, you can see that about 60% of the mice lived much longer than even the vehicle set. So very much slowed down that metastasis progression in 60% of the mice. Now, for reasons that we still don't understand, although we're tracking it, about 1/3 of the mice did not benefit from TIMP1 targeting. And we do know that the TIMP1 targeting drug worked in all of these, in that TIMP1 was gone in all of these mice. But again, for some reason, about 1/3 of them did not benefit. So that's that secreted factor component to our studies. But like I said, we also did that single cell sequencing to ask what cells are present in the liver as well. So I know probably nobody here is used to looking at these, but what this is a map of all the immune cells that were present in that liver. I'm just showing the immune cells because of this finding that I'm about ready to tell you. But when we looked at the map of the cells present in the FOLFIRINOX treated liver versus no treatment, we found a profound depletion in these cells that are labeled KC that are called Kupffer cells. Now, Kupffer cells are a liver-specific resident immune cell type, only found in the liver. And in fact, your liver is born with all the Kupffer cells as it's already developing. So we found this very, very striking and also concerning. The reason why it was concerning was because Kupffer cells have already been shown to be very important for protecting your liver against disseminated tumor cells entering the liver. And that's because they sit in essentially your liver blood vessels and they just eat bad stuff. It's their entire job. It's called phagocytosis. They just eat bad stuff that's going into your liver. So is it possible we're possibly leaving the liver at higher risk of metastasis because that chemotherapy is depleting those Kupffer cells? The other striking thing about this is we saw an expansion, you can see here, of something called M2-like macrophages. And those, by the way, are macrophages that are known to help tumor cells survive. So now we have this shift from Kupffer cell loss to an expansion of pro-tumor macrophages. And we're actually doing studies right now to ask, is it possible that following the injury from chemotherapy, those Kupffer cells are trans-differentiating into those pro-tumor macrophage subtypes? We have studies ongoing right now that I'm very excited to look for in the future here. Okay, so now I have my conclusion slide, which I think is great. So enough time for more questions if you guys want. But where are we going from here? So following up on the question that was already asked, why don't we treat people with therapy to prevent this? Great, I completely agree. So step one, we are working to define a biomarker panel to determine which patients are at high risk of recurrence following surgery. So my group, in conjunction with the tissue bank, which I'll mention on the next slide, we conducted an analysis of looking at factors in the serum, so their blood, they were all surgically resectable stage match early patients. The blood was taken at the time of diagnosis or at the time of surgery. And we looked for 212 different proteins that may be linked to metastasis. And within those patients that we studied, half of them recurred with disease very quickly after surgery, and half of them never recurred. And we're very excited by this data. There were actually many factors that were different between that early recurrence and late recurrence patients. And when we're working with biostatisticians right now to come up with a panel that could tell us that you are at high risk of recurrence and we need to be treating you ASAP. So we hope that that data comes back within about a month, and then we will validate it on additional patients in order to say that this is something that should move forward. We are also working to identify new therapies to intercept metastasis. And what do I mean by intercept? I mean prevent the survival and outgrowth of those microscopic disseminated tumor cells that are likely residing in about 70% of the patients at surgery. I just told you about 2 stories where we can do mouse modeling to identify new factors contributing to metastasis. And then through those discoveries, we aim to test new drugs that could then be moved into the clinic to prevent metastasis in patients. We are also developing a personalized screening platform using those mini tumors grown from patients' own resected tumors. So again, part of the tissue bank, which I'll mention on the next slide, our tissue bank, those patients who decide to participate in our bank, we collect serum from them throughout their treatment. We also collect the tumor at the time of resection. Part of that tumor is banked, and then part of that tumor goes to research directly. Part of it comes to my lab, part of it goes to our colleagues' labs. And what we do with those is we study that person's tumor. What can we learn about your tumor? So what we've been doing is growing those mini tumors in a dish, 3-dimensional space, using each individual's own tumor. And then we're working towards essentially having a screening platform to screen those little mini tumors against a panel of FDA-approved drugs. So the goal with that is to say, okay, this person's tumor really responded well to this group of FDA-approved drugs. So if that person does recur, they can then be treated with a treatment that we think their tumor is more sensitive to. So it's a more personalized screening platform, or it's a more personalized medicine instead of just giving that person more chemotherapy. We also really think a lot about patients who are diagnosed with late-stage disease. You know, somebody on the call mentioned that they were diagnosed with stage 3. Our group is working very hard to find new therapies for those patients. You know, I mentioned KRAS inhibitors. That wasn't developed here, but of course we will be using KRAS inhibitors as soon as they're approved for use. And we expect that to be actually relatively soon. However, although patients do often respond to KRAS inhibition, we already know that resistance does occur, and those patients' tumors will eventually stop responding to KRAS inhibitor and then start growing again. So what do we do? What do we do when you are no longer responding to chemotherapy? You're no longer responding to RAS inhibitor. We are developing cells that are cell lines, they're human cell lines, pancreatic cancer cell lines, and we're creating resistant cell lines to all the current therapies. My group is doing this. It's been an effort of love. It's been challenging, but we're moving forward with it. But our goal is to have all of these resistant cells so that then we can then apply this genetic approach, which I won't get into today, that simultaneously tests for about 4,000 FDA-approved drugs, so that we can say, okay, if you're resistant to this treatment or this treatment or this treatment, you're now more sensitive to this other FDA-approved drug. And then also one thing I want to mention, I am not doing this, but my colleagues are, is that they're developing personalized drug screening platforms using the biopsy from your disease at the time of diagnosis. And this will be particularly helpful for those who already have metastasis. So we take a biopsy of the metastasis. We can essentially use that tiny little biopsy to test drugs in real time. And then our goal is to get that back to the patient and say, okay, we anticipate you will be more susceptible to this treatment. Now, because that tissue is so small, The advantage of that right there is that it's very rapid, but the tissue is so limited because we didn't grow it up in those mini tumors, that we can only test a few drugs at a time. But what we do is my colleagues, use your mutation information to anticipate which drugs we think you'll be most responsive to, and then test those few drugs that we think you're going to be best responding to. And then again, the goal will be to get it back to the patient. Now, all of those platforms I just said, we've been working very aggressively towards over the last about 2 years. And we're really at the cusp of having this programmatic personalized medicine treatment for each individual patient. And so we're very excited to keep that driving forward. Unfortunately for all of us, we think that just sometimes, the clinic moves slower than we wish, but only because limited by FDA approval and what essentially this protective review board, or it's called an institutional review board, will let us do. And the reasons for that is obviously to protect patients. And we agree, of course, the patient safety is number one, but we're working as hard as we can to get all of these platforms back to the patients as fast as possible. And so with that, I do want to just give credit to the larger group. And also first, we are just so grateful for the support of patients and their willingness to participate in the tissue bank and in the efforts ongoing at MCW here. I benefit so much from the about 15 years that this tissue bank has been running. Again, like I said, I've used patient serum that they donated to study to try and find new factors of early recurrence. And we have really promising hits towards that. I also use patients' own tumors to understand why they respond to some treatments over others. So do my colleagues, Dr. Dave So and Tommy McFall. And then we have all worked very collectively to continue broadening the vision of how to make pancreas cancer a disease that's more of a chronic disease rather than something that's just unfortunately a disease that we have no treatment options for. So my final slide is I always like to give this quote from Hope Jaron. She was actually a Midwest archaeologist, and she had this kind of famous quote that I love, and what she said was, "A cactus does not live in the desert because it likes the desert. It lives there because the desert has not killed it yet." And I don't think she knows this, but I think she was actually talking about cancer. And that's because I think of cancer as especially that microscopic disseminated disease. It doesn't belong there. It doesn't want to live there. Our body's pretty good at clearing it. There's just an unfortunate small number of times that our body doesn't clear it. And how do I step in and our group step in to get that final little pieces of cactus out of a person? And with that, I will stop my slideshow so that we can chat as a group if anybody has additional questions.
There's some more questions in the chat.
Okay.
One said, if someone does not have a KRAS mutation, does it mean that the chance... Oh, I missed one. I'm so sorry. If KRAS mutation is 95%, what does it mean to not have the KRAS mutation?
Yeah, yes, great question. And in fact, if you are, we call it KRAS wild type, so you don't have a mutation, those patients actually do better than patients with KRAS mutations. They just tend to be more responsive to chemotherapy, and their survival is usually longer. So although there is no targeted therapy, there still can be a targeted therapy for them based off of other mutations. But yes, you don't take the KRAS inhibitor, but you actually have at baseline a better prognosis than those that do have a mutation.
I think that answered the other question. It was, if someone does not have a KRAS mutation, does that mean the chance of reoccurrence is slim?
It's lower for sure. And and I did highlight KRAS because there's so much excitement about it. By the way, if anybody wants to, feel free to turn on your camera or speak, but you don't have to if you don't want to. But there are other known targetable mutations in the cancer. There's just a lot of hype around KRAS right now because it was undruggable for so many years, and there were so many patients that just had no options because of that KRAS mutation. And now we have a drug to at least move the bar a few more months.
Okay, the next one is, have they found that Gemabrax affecting the lungs adversely as oxaliplatin does the liver? Also said amazing work that you're doing.
Thank you. If Gemabrax injures the lung, is that what you asked for?
Affecting the lungs adversely as oxaliplatin does the liver.
Great question. So we haven't moved into that, but we're very interested in moving into the lung next. The reason why we started in the liver was because it is the most common site of metastasis. And then just to let you know, those that develop um, metastasis in the liver, let me say that backwards. Those that develop metastasis in the lung have better outcomes than those that develop it in the liver. And one thought of that is that it tends to be when your tumor goes to the lung, there's a lot of immune cells there that are quite good at keeping that metastasis under control. And for some reason, when it goes to the liver, there's just not that many immune cells. So it's kind of the liver is left kind of fighting on its own, if you will. And now our data shows that it's possible that the chemotherapy is depleting some of the most critical immune cells there to fight your cancer.
So, the next one is, what do you think of Signatera tests as a predictor of reoccurrence post-surgery?
Great. We are actually working with Signatera as we speak. Our group is, like I said, we take every approach possible. We haven't been able to validate it ourselves, but we are very interested in following that data. And actually, Dr. Dave So has been working, and the group has been working to set up a collaboration with them, as well as other companies, because we don't want to, stick to just one opportunity. We want to explore them all. So we will do anything we can to work with these companies and beyond, and obviously our own work as well, to better anticipate who needs treatment. Oh, and notably, the blood test can also be used to not only predict recurrence, or at least that's what the hope is, but it's also actually originally developed to follow treatment response better. So, as in, if you're responding well to treatment, your signal will be better. If you're not responding, the signal will be worse, and that'll help you rapidly change treatment.
All the questions in the chat for now, Nikki.
Okay, wonderful. Well, what I always love the questions that come out of the group. It's, meaningful to hear that you guys are not only listening, but also asking your own questions about, this disease and where we're going. And I just am very grateful.
Thank you, Nikki. Oh, there's one more.
Okay.
Can you read it? I can read it. I went on Gemabrax because Fulfirinox seemed to stop working. I had reoccurrence with nodules in lung, lymph nodes in lung area, and small one in liver and peritoneum. The Gemabrax has caused lung inflammation severely.
Okay. I'm very sorry to hear that. Number one, your disease progression, and number two, that you didn't respond. You responded poorly to Gemabrax. It is a drug combination that people tend to have less toxicity on, but that is just the heterogeneity of people. Unfortunately, treatment response is very unpredictable right now, and so typically Gemabrax is people tolerate that much better. Fulfirinox is very, very rough. So now that being said, I don't know why your lungs would be particularly injured by that, but that could be a question for Dr. Kamgar as well. Yeah. Oh,
Someone also asked, is hyaluronic acid bad for pancreatic cancer patients?
you may have heard there was a trial to deplete the hyaluronic acid. Maybe is that where that question's coming from? I didn't get into it, but our lab also studies a lot of we call it the extracellular matrix. So it's this matrix between cells that is composed of hyaluronic acid, collagen, fibronectin, elastin. A lot of people here may know what collagen is. I drink collagen. I don't know if you guys drink collagen, but it's very good for your skin and your hair. Now that being said, what your tumor produces is not what you put in your body. And I really want to emphasize that, because if you drink collagen, it's not going to feed your tumor. Your tumor actually creates its own collagen because it loves it so much. And the same for hyaluronic acid. So we know that hyaluronic acid helps tumors grow, but that is not the same hyaluronic acid that maybe you put on your skin, for example. Now the efforts towards targeting hyaluronic acid to treat patients, those clinical trials did fail. But within that clinical trial, there was a subset of patients that responded very, very well to hyaluronic acid treatment or targeting treatment. And so now there's efforts again back in the research realm to try to identify who those patients were and figure out, okay, great, can we do another trial now with a selected group of patients that we know will respond better to that treatment? And so I anticipate maybe in the next couple years, they might run another trial just for those that should respond.
I didn't know that was a thing, so I learned something new today.
Yeah. Yeah, I always, especially because if I show people those little mini tumors we grow in a dish, they're embedded in a collagen network. And I always get the question, oh my gosh, should I stop drinking collagen? It's like, no, it's different.
I drink collagen too and put the hyaluronic
Yeah.
acid on my face every day. So
Right. I do the hyaluronic acid in the mornings. I do collagen. I do
yeah.
all. So, yep. But that was
Okay.
great questions. Great question.
Yeah.
Yeah.
Someone just said thank you so much.
Yeah.
Hopefully there's something that could be done if I can't do chemo.
Yes, I definitely, yeah. This is why we work so hard to do what we do here. We're really working towards the best for all of you guys.
All right. Thank you everybody so much for tuning in to Nikki's presentation. Again, this will be recorded, and tomorrow we have our genetic counselor, same time, 5 p.m. Central, if you guys want to hop on there. Otherwise, thank you, Nikki. Thank you
Yeah.
everybody, and have a lovely evening.
Thank you. All right. Bye. Good night, everyone.